You are at the bedside, or maybe you're sitting at the nurse's station reviewing the chart, and you are staring down one of the most notoriously stubborn clinical scenarios we face.
Oh, absolutely. It's a tough one.
You are treating MRSA, methicillin-resistant Staphylococcus aureus septic arthritis. And to make matters even more complicated, it's in a prosthetic joint.
Which just changes the entire calculus.
It really does. And the critical question on the table,
Mm.
the one that's probably keeping you from finalizing those discharge orders, is this. Do you commit your patient to a full 6 weeks of intravenous antibiotics? Or is it actually safe to shorten the IV course and switch them over to oral therapy sooner?
Right, and it's the ultimate clinical tug of war. I mean, on one side, prolonged intravenous treatment just feels thorough.
Yeah.
Feels like we're doing everything in our medical power to eradicate a really highly aggressive pathogen. But we all know that thoroughness comes at a steep, tangible cost.
Oh, for sure.
You're guaranteeing longer hospital stays, or at the very least, prolonged outpatient IV access. And that inherently brings the risk of PICC line complications, secondary bloodstream infections, deep vein
The
thrombosis.
massive disruption to the patient's quality of life.
Exactly. It's huge.
And on the flip side, shorter IV courses seem incredibly appealing for all those exact reasons. We want to get the patient out of the hospital. We want to pull those lines as soon as practically possible.
Right.
But the overriding fear, the thing that keeps us up at night and makes us hesitate with the pen, is infection recurrence.
Nobody wants that.
No one wants to be the clinician who stepped down the IV too soon, only to have the MRSA come roaring back in that prosthetic joint, potentially costing the patient their limb, or, worse.
Which is exactly why our mission for this deep dive is to tackle this clinical dilemma head on. We are going to critically evaluate the data to challenge the dogma of that automatic 6-week IV course.
Let's do it.
We need to analyze why our standard clinical instincts might actually be leading us astray in this specific scenario. We'll break down the pharmacokinetics and the microbiology of why oral step-down works, and then build a concrete framework for when you can transition to oral therapy safely.
Let's unpack that deeply ingrained instinct first, because, man, it is powerful.
Oh, it's practically muscle memory at this point.
It is. For most of us, the default posture, the absolute natural reflex when we see MRSA and prosthetic joint in the same chart, is to just lean heavily toward that full 6 weeks of IV antibiotics. It
Rare.
visually and psychologically feels safer.
It does feel safer, and we really have to deconstruct why it feels that way to understand why we need to evolve past it.
Right.
When you're dealing with a pathogen like MRSA, which is incredibly tough and frankly forgiving of absolutely zero clinical errors,
Yeah.
you desperately want guaranteed delivery.
Right, because we know exactly what MRSA does when it encounters hardware. Treating MRSA on a prosthetic joint isn't like weeding a garden. It's more like trying to eradicate toxic mold from behind the drywall of a house.
Oh, I like that analogy.
Right. Like if you don't physically tear out the rotting drywall, which would be the suboptimal surgery, or retain hardware, it doesn't matter how much industrial bleach you spray on the painted wall.
The foundation is still compromised.
Exactly. The foundation is compromised. And we use IV antibiotics like that industrial bleach because it gives us the illusion of maximum control. We just assume that flooding the bloodstream guarantees high drug levels directly at the site.
That is a phenomenal way to visualize it. We use the IV line to essentially bypass all of the physiological doubt. We don't have to worry, did their gut absorb it? Did they take it with the right food? Did the drug actually reach systemic circulation?
We just know it's in the vein.
Exactly. The IV line seemingly eliminates the terrifying variable of the human GI tract. But here is where the logic of that bleach-on-the-wall instinct starts to break down when you subject it to actual pharmacokinetic scrutiny.
Okay, lay it on us.
The paradigm shift we have to make is understanding that the duration of the intravenous phase specifically is taking a massive backseat to two entirely different factors.
Wait, so if the sheer number of days a drug is pumped directly into a vein isn't the primary driver of success, what is?
The total length of the antibiotic treatment, meaning the IV and oral phases combined, and exponentially more critical, how aggressively and comprehensively the surgery was performed.
Wow.
Those two elements dictate your clinical outcome way more than the IV duration alone.
Let's just pause on that for a second because the implications are huge. What this means for the clinician writing the orders is that transitioning to oral antibiotics earlier is just as effective as keeping that PICC line in for 6 weeks.
Provided the surgical management achieved adequate source control.
Right, provided the surgery was good, and the patient's clinical trajectory is moving in the right direction.
Right.
We've basically been equating the route of administration with the quality of the cure.
Exactly. When really a highly bioavailable oral drug does the exact same job once it hits the bloodstream.
Once it's in, it's in.
Precisely. If we look at the pharmacokinetics of certain oral agents like linezolid or some of the fluoroquinolones, assuming they're susceptible, obviously their bioavailability is incredibly high, sometimes approaching 100%.
That's practically IV equivalent anyway.
Exactly. That means the area under the curve, the actual drug exposure the pathogen sees, is essentially identical whether you pushed it through a plastic tube in their arm or they swallowed a pill. The bacteria deep in that joint tissue cannot tell how the drug got into the serum. It only cares about the concentration it encounters.
I hear that. And, the pharmacokinetic argument makes perfect sense on paper, but I have to play devil's advocate here and push back on the clinical realities. We're clinicians, right? We want to see the hard population-level stats. If we look at recurrence rates, readmissions, or mortality rates for MRSA PGI, doesn't 6 full weeks of IV give us at least a slight statistically significant edge over an oral step-down?
You would think so.
I mean, surely there's a robust, data-driven reason this became the gold standard dogma in the first place.
That is the most important question you can ask when evaluating standard of care. And the answer is often quite jarring to hear. No clear, definitive advantage has ever been shown for 6 full weeks of 5E treatment in preventing recurrence, reducing hospital readmissions, or lowering mortality in these specific cases compared to a well-managed oral step-down.
Wait, never.
Never.
We have been subjecting patients to the risks of prolonged central lines, the DVTs, the secondary bacteremias, all based on a protocol that doesn't actually have superiority data to back it up.
It has never been conclusively shown to be superior. However, and this is a really vital caveat that every prescribing clinician must understand, our confidence in this specific body of evidence is low.
Oh.
The data we have is not bulletproof. We do not have massive, perfectly controlled, multi-center randomized trials that conclusively end the debate forever.
Right. It's hard to blind a study like that anyway.
Exactly. Much of what we rely on comes from observational data, retrospective cohorts, and, extrapolated findings.
So it's not necessarily that the evidence proves an early oral step-down is vastly universally superior. It's that the evidence utterly fails to prove the 6-week 5E course is the mandatory risk-free lifesaver we historically assumed it was.
Exactly.
The data just doesn't justify the collateral damage of the IV line.
You hit the nail on the head. The evidence gap goes both ways. Because the data isn't definitive, what this truly means practically is that you are trading the perceived mechanical certainty of the IV line for the rigorous responsibility of clinical follow-up.
You can't just send them off and forget about them.
Exactly. You cannot simply switch a complex PGI patient to oral NEDs, hand them a discharge summary, and wash your hands of it. Close, vigilant monitoring of the patient's overall treatment plan, their inflammatory markers, their joint function, it becomes absolutely essential.
That makes a lot of sense. The burden of care basically shifts from maintaining vascular access to maintaining clinical vigilance.
Exactly.
So if we are moving away from the 6-week rule and we need to be flexible, what are the specific variables that give us the green light? If I'm looking at my patient's chart, how do I actually build this new decision framework? What tells me it is definitively safe to make that switch to oral medications?
We can build this framework by looking at 3 core requirements. If you have these 3 variables fully optimized, your confidence in moving to an oral step-down should be very high.
Okay, let's hear them.
The first, and arguably the most important, is the surgical variable. More aggressive, comprehensive surgical management directly reduces the need for prolonged IV antibiotics.
Let's dig into the why there. Because a prosthetic joint infection isn't just free-floating bacteria in synovial fluid. We're talking about biofilms.
Yes, the dreaded biofilm. When MRSA encounters a foreign body like cobalt, chrome, or titanium, it doesn't just multiply, it fundamentally changes its behavior.
Right.
It secretes this extracellular polymeric substance, this thick, slimy matrix, and forms a biofilm. And inside that biofilm, the bacteria shift into a metabolically dormant stationary phase.
And that's the nightmare scenario, right?
Yeah.
Because most of our heavy-hitting bactericidal antibiotics, like our beta-lactams, they require the bacteria to be actively dividing and building cell walls to actually kill them.
Exactly.
If the MRSA is just hibernating inside a slime layer on a piece of metal, You could pump IV drugs into the patient for a year and it wouldn't clear the infection.
Precisely. The antibiotics often just cannot penetrate the biofilm effectively. And even if they do, the bacteria are phenotypically tolerant anyway.
So why?
This is why the surgical variable is paramount. Whether it's a thorough GARE procedure, debridement, antibiotics, and implant retention, or a complete one-stage or two-stage exchange, the surgeon has to mechanically disrupt and remove that bioburden.
They have to get the slime out.
They have to get it out. Aggressive surgery lowers the bacterial load to a level where the immune system and the antibiotics can actually finish the job. If that mechanical removal is successful, the root of the antibiotic becomes completely secondary.
So the physical variable, the surgery must be rock solid. What's the second requirement in our framework?
The chemical variables.
Yeah.
So the pathogen and drug factors. Obviously, the MRSA must have proven documented susceptibility to the oral agent you intend to use.
We are not guessing here.
We are not guessing or empirically stepping down. And equally important, the oral agents you select must have highly reliable bioavailability and excellent tissue penetration.
Okay, I want to challenge that slightly. How do you actually measure reliable absorption in a complex patient? A lot of these patients have multiple comorbidities. They might have gastroparesis or, they're on a dozen other medications. Are we just glancing at a standard pharmacokinetic chart and assuming their gut works perfectly?
That is a phenomenal point, and honestly, it's where the art of medicine meets the science. You cannot just blindly trust the textbook bioavailability.
Right.
You have to actively assess the patient's gastrointestinal function. Are they absorbing their diet? Are they experiencing severe diarrhea or vomiting? Are they taking interacting medications?
Like what?
Like calcium supplements or antacids. Those will physically bind to a drug like a fluoroquinolone in the gut and just prevent it from entering the bloodstream entirely.
Oh, wow. Yeah.
If there is any physiological barrier to absorption, that drug is not reliable in that specific patient, period.
Which perfectly sets up the third requirement, the behavioral variable, patient adherence.
Exactly. The patient absolutely must be able to tolerate the oral medications, and they must be highly, impeccably reliable in taking them.
Because if they miss doses, we're back to square one.
Worse than square one, you're breeding resistance. If a patient is dealing with significant cognitive decline or housing instability, or they simply have a track record of poor compliance, an oral step-down strategy becomes incredibly dangerous. You cannot step down to oral therapy if the pills are just going to sit on a nightstand.
So, to summarize the green lights, we need aggressive surgical bioburden reduction, a highly bioavailable drug matched to proven pathogen susceptibility, and a clinically stable patient with a functioning gut and a high likelihood of adherence.
That's trifecta.
When all of those align, keeping the IV in is just treating our own anxiety, not the patient.
Well said. Very well said.
But let's look at the other side of the coin. What are the absolute red lights? When do we pull the handbrake, abandon this flexible step-down approach, and just commit to the prolonged 5V therapy?
There are strict exceptions where the 6-week 4V course remains the absolute safest, most medically warranted path. First, addressing the chemical variable. If the bacteria's susceptibility to the available oral antibiotics is borderline or uncertain,
Right.
or if the only susceptible oral options have known poor absorption profiles or terrible bone penetration, you cannot trade the pharmacokinetic certainty of an IV for oral uncertainty when a joint is on the line.
Makes total sense. Don't
Yeah.
risk it. What about the surgical exceptions?
This is a critical one if the surgery was suboptimal, and we need to be very specific about what that means in clinical practice.
Okay.
This means incomplete debridement where necrotic tissue or obvious bioburden was left behind. Or, crucially, if the decision was made to retain the prosthetic implants when removal was actually clinically indicated and the standard of care.
But, let's live in the real world for a second. Sometimes a patient is profoundly hemodynamically unstable, or they have such severe cardiovascular comorbidities that putting them under general anesthesia for a massive 2-stage revision arthroplasty would likely kill them on the table.
Oh, absolutely.
Sometimes retaining the hardware is a salvage maneuver, not a mistake.
You are absolutely right. Suppressive therapy or retaining hardware in high-risk surgical candidates is a very real reality of clinical practice. But the point is, in those salvaged scenarios where you know there is a massive undisturbed biofilm still sitting on that implant, you do not compound the risk by stepping down to an oral regimen prematurely.
Ah, I see.
If the hardware stays when it optimally shouldn't, the IV stays too. You need guaranteed high-dose delivery to keep that retained infection from going systemic.
So a compromised physical foundation demands maximum chemical weatherproofing.
I love that. Yes.
What else is on the red light list?
Clinical signs of treatment failure during the initial therapy.
So if things aren't getting better,
Right. If you are 2 weeks into the IV course and the joint is still red, hot, and exquisitely tender, or if their CRP and ESR are climbing instead of falling, or if the patient is still febrile, you absolutely do not step down.
yeah, that's not the time to back off.
Exactly. An oral switch is a transition of success, not a rescue maneuver for a failing regimen. You stop, you reassess, and you probably call the surgeon back.
And I know there are also specific pharmacological exceptions, particularly regarding adjunctive therapies used for biofilms. Let's talk about rifampin.
Yes, rifampin is the classic exception here. Rifampin is incredibly effective against staphylococcal biofilms because it actually penetrates the matrix and targets the bacteria in that stationary phase we talked about.
Right, he's one of the few drugs that can do that.
Exactly. But there's a massive catch.
The resistance profile.
Exactly. Resistance to rifampin and MRSA can develop via just a single point mutation in the RPB gene, which codes for the RNA polymerase.
Wow, just one mutation.
Just one. If you just give a patient oral rifampin when they have a massive bacterial load in that joint, the sheer number of bacteria practically guarantees that a resistant mutant will emerge and flourish.
Which is why we use an IV lead-in protocol. We hit them with high-dose bactericidal IV antibiotics like vancomycin or daptomycin for a period of time to drastically drop the overall colony-forming unit count.
Right, to clear out the bulk of it.
We reduce the mathematical probability of a resistant mutation existing. And only once the bioburden is slashed do we introduce the rifampin.
And you cannot bypass or shortcut those specific IV lead-in protocols just to get the patient on an all-oral step-down sooner. You really have to respect the mechanism of resistance.
This is brilliant. Okay, beyond knowing the physiological green lights and red lights, let's talk about the psychological side.
Here's the big one.
Right. As clinicians, we are constantly trying to synthesize vast amounts of literature, and sometimes we connect clinical dots that fundamentally shouldn't be connected.
Yeah.
Where do we misinterpret the data when it comes to stepping down MRSA joint infections?
This is where we get into the cognitive traps of evidence-based medicine. We desperately want broad rules to simplify our complex days, and that leads to dangerous false equivalencies. The biggest trap I see is clinicians applying findings from native joint septic arthritis directly to prosthetic joint infections.
And they do that because they see septic joint and assume the pathology is identical.
Exactly.
But as we discussed with the biofilm, a native joint and a prosthetic joint are completely different ecosystems. Native joints, even when highly inflamed and infected, they still have a functional microvascular supply. You have synovial fluid turnover, you have macrophages and neutrophils that can actually physically reach the infected tissue.
Exactly. A prosthetic joint is just a massive avascular piece of cobalt, chrome, titanium, or polyethylene.
It's just dead metal.
Exactly. The immune system cannot perfuse metal. The antibiotics don't easily reach the interface between the cement and the bone. You cannot look at a study showing a high success rate for a 14-day oral course in a native knee infection and assume your MRSA knee replacement will respond the same way. The avascular surface changes the entire calculus.
What's another common trap?
Extrapolating non-MRSA data to a MRSA case.
Ah, yeah.
MRSA simply plays by its own virulent rules. It has an extensive arsenal of toxins, immune evasion proteins, and adhesins that allow it to stick to hardware better than almost anything else.
It's sticky.
Very. If you are reading a robust meta-analysis that concludes prosthetic joint infections do exceedingly well on early oral step-down, you have to actually dig into their supplemental data.
To see what bugs they were actually treating.
Right. If their patient cohort was 80% coagulus-negative staph or susceptible streptococci, and they only had a tiny, statistically insignificant fraction of MRSA cases, you cannot apply that paper's conclusion to the MRSA patient in front of you.
That is such a vital reminder. We have to look at the inclusion criteria and the actual microbiology of the cohorts we are relying on. And the last trap, which we touched on earlier, is relying on the wrong outcome metrics to make our choices.
Yes.
We shouldn't be agonizing over whether 6 weeks of IV versus oral step-down magically improves long-term all-cause mortality, because the studies simply haven't been powered or designed to give us a definitive answer on that specific variable.
Precisely. You don't base this decision on a vague hope of improving population-level mortality stats. You base it on the clinical realities right in front of you. The surgical success, the microbiological susceptibility, the pharmacokinetic reliability, and the patient's adherence.
This has been incredibly clarifying. We've taken a deeply entrenched, almost reflexive clinical habit, the automatic 6 weeks of IV, and really examined the mechanical, biological, and literature-based truths beneath it. Let's distill this entire complex discussion into a single, highly memorable rule that a clinician can carry with them on their rounds.
I love that. If we have to reduce it to a core philosophy, it would be this. For MRSA prosthetic joint infections, prioritize your aggressive surgical management and the total combined antibiotic duration above all else.
Use shorter 5E courses followed by a carefully planned oral step-down when the surgical source control is excellent, the pathogen susceptibility is proven, the oral drug is highly bioavailable, and the patient is reliable.
Right.
But aggressively reserve prolonged IV therapy for those compromised situations. Uncertain gut absorption, poor adherence profiles, or suboptimal surgical control where the hardware had to be retained.
That perfectly captures the necessary balance. We aren't blindly abandoning 5E therapy. We are finally using it precisely when the biological and structural realities of the infection demand it, rather than just buying the most expensive, most invasive insurance policy by default.
We started today by acknowledging how incredibly murky the diagnostic and treatment landscape for a MRSA prosthetic joint infection truly is. We don't have a perfectly clear algorithm that spits out a binary answer.
We really don't.
We have to navigate the gray areas using deep physiological understanding, recognizing that our old, comfortable defaults might just be an illusion of safety.
We do, and as we refine our understanding of these infections, we have to look toward how the landscape is going to shift.
So as you head back to the floor, or as you sit down to finalize those complex discharge orders, what is the ultimate takeaway? What should we be anticipating next?
Consider this. We have spent this entire time debating the systemic delivery of antibiotics, whether we flood the whole body via an IV line or flood the whole body via the gastrointestinal tract just to reach a highly localized piece of infected hardware.
Right.
But as we move toward the clinical reality of targeted bacteriophage therapy or, the implementation of advanced bioabsorbable antibiotic-eluting beads that can be packed directly into the joint space by the surgeon,
Oh, wow.
releasing massive, sustained, localized concentrations of drug without causing systemic toxicity. This entire stressful debate over systemic IV versus systemic oral delivery might soon become a completely obsolete historical footnote.
That's wild to think about.
Right. The future isn't about how we deliver the drug to the bloodstream. It's about how we deliver the cure directly to the metal.